Introduction to Nursing Concepts, Nursing Process, Part 2. The nurse decision-making process is a big part of what we will be looking at in this segment, subjective versus objective, and then also the difference between the medical and the nursing assessment that we do. The nursing process is very unique to nursing. It gives us a common language and also a common ability to document about our patients. It's a very systematic approach that nurses use to gather, critically examine, and then analyze the data. Next to the client's response to the health problem is identified, and then what we expect the outcome to be. We plan our interventions or what we will do, and then finally we evaluate, was that nursing action effective in helping that patient? We know learning is a lifelong process, and to be a lifelong learner, we have to also be flexible and willing to receive new information. Learning and thinking are inseparable. As a professional nurse, you must think and anticipate, and it involves looking ahead and asking a lot of questions. Don't allow your thinking to become routine. Oh, this is just another appendectomy, or oh, I've had a total hip replacement before. I know exactly what's going to happen, because every patient has something different happen. Subjective and objective are very different. Subjective is what the patient says. I have chest pain. Whereas objective is what you observe. His blood pressure is 110/88. He has +2 edema to his lower extremities. So subjective is the client's perception of what is going on with their health, and objective is what we observe through our senses, feeling, smelling, observing, and in our assessment that we complete. Objective data versus opinion. Objective is what we notice that tells us about that patient, whereas our opinion might be not correct, and we need to be very careful with our opinion. If a patient comes into the ER and they smell of alcohol and they're slurring their speech and they're very loud and belligerent and unsteady, it would be very easy to chart the patient is drunk. But we don't know that for sure. What if they're having a stroke and they're having a CVA and that's causing their symptoms? So we want to chart objectively. The patient is unsteady on their feet. The patient smells of alcohol. We're not saying they drank, we're just saying they smelled of. So do you see the difference in objective and also the opinion? Medical is focused on the illness, injury, or the disease process, whereas nursing is focused on that client's response to actual or potential. Actual means they have the problem now, and potential means they're a risk for it. Somebody that's overweight, that's having TIAs or mini strokes, is a risk factor for having a stroke. So nursing and medical are very different. Medical, they plan medical interventions, and nursing, we look at those interventions and we modify that response to health. So as we move along, then we see the medical is determined by the doctor or physician. It's disease related. Things like pneumonia, psoriasis, prostatitis, acute renal failure would be a medical diagnosis. Nursing then is determined by a nurse, and it's their response to that illness, disease, or state of health that they're presently in. And our examples are things like impaired gas exchange. A patient with pneumonia might have impaired gas exchange, and that's how we write our nursing diagnosis. A patient in acute renal failure might have altered urinary elimination. So you can see we've paired the sides of those up together. Our nursing process then enables the nurse to identify their health needs, determine our priorities, and each time that you see I have a list of 5 bulleted nursing diagnoses, it's going to be very important for you to start prioritizing. If the patient had all 5 of those nursing diagnoses, which one am I most concerned about? Because your nursing boards will have a lot of questions that are priority. Will that nurse know what to do first, or what thing to take care of first? The nursing process helps us establish goals and outcomes, deliver our interventions, and evaluate again, was our care effective, or do we need to look at doing something differently because they're not responding to the care that we have been giving. The purpose purpose of the nursing process is to identify, diagnose, and treat actual or potential human responses to health and illness. Our 5 steps in the nursing process always go in this way. We assess the patient. That means we go in and we look at them, we take their vitals, we talk to them, we find out why they're being admitted, and then we come up with our nursing diagnosis. And those have to be prioritized, and again, they are going to be actual or potential. Our plan then is the things that we are going to do to get them better based on their diagnosis. Then we implement or do, and finally we evaluate. Was the nursing care that we planned out the best? Did we get that patient walking in the hall? Did they eat 50% of their meal? So our definition is listed here. Again, it's a way of giving individualized nursing care. So you can't go in and say, oh, this person has pneumonia and I am going to write a diagnosis for them, because maybe what one pneumonia patient has for a nursing diagnosis is going to be very different than the next patient that is admitted with pneumonia. Our first part then again is assessment. We have to think about what kind of data do we collect, and we will get that from the chart, we will get that from the patient, we will get that from our assessment of doing our vitals and our head to toe assessment, and we can also get that information possibly from family members. So there's a lot of ways to collect data. Remember, we have subjective and objective. So subjective is what the patient says, and objective is what we notice or observe. We want to do it in a very organized way of getting a health history, and then perform that head to toe or that physical examination, getting all of the things that we need, including medical records, our laboratory values that have been drawn, any other diagnostic tests. So a typical question might be, a client is admitted to the hospital with shortness of breath. And if that was the test, I probably would not put the word shortness of breath. I would put the word dyspnea, D-Y-S-P-N-E-A. As the nurse assesses this client, the nurse is using the process of, and the answer is B, data collection. We are at the point where we are collecting data. So we are in that next phase now where we've assessed the patient and we've collected our data, and now we need to come up with our plan. We establish our priorities. Airway is always going to be first. If the patient is not breathing, if they're dyspneic and short of breath, that takes priority over the fact that maybe they're constipated or they're feeling lonely. So we develop our goals and outcomes, we think about our plan, we write them down, and then we go and do them. Our implementation phase is carrying out that plan. It's doing the specific activities. It might be assessing for pain, giving massage, ambulating the patient. We want to organize our resources. We want to make these specific activities help the client meet his goals. And then finally, we evaluate. Did what we do give us the outcomes that we wanted? So we measure the extent to which the goals and outcomes have been met, and they either are fully met, partially met, or they weren't met at all, they were unmet. And we will determine that then when the date comes that we have set. So if my goal was that the patient will walk in the hall 20 feet by Friday, when Friday comes and I look at that goal that was written and I say he's walking 20 feet every day, he has met that objective. We can modify it at that point then and say, you know what, this patient isn't responding. We need to change our care plan and maybe make it that the patient sits in the chair 20 minutes a day and he can tolerate that without getting deoxygenated. So we want to assess how the client responds. We want to compare it to how they're doing, and then we want to judge the response that they have to make our decisions for future cares. Our nursing process is organized and systematic. It allows an orderly, sequential approach to problem solving, and all of the steps are interrelated, so you have to go in the order, but they all relate back to each other. It is interpersonal. It's always patient-centered. You will not see a nursing goal that says the nurse will, because it's not about the nurse. It's about the patient. It's not about the tasks either. So it encourages nurses to work together to help a client or patient achieve their specific goals. And it's very goal-oriented. Just like your goal is to get through the nursing program in 2 years and pass your NCLEX, the goal for the patient is to whatever we set up or design for them that's goal-oriented. And then it has to be humanistic. It has to be unique to that individual person. Nurses do not provide assembly line care, so no two patients are going to be exactly alike. So many times when students get to clinical and they see their patient the night before the first day of clinical, they might go in and visit with them and say, I'm going to be your student nurse tomorrow, and I just wanted to come in and say hi, how you doing? And this allows the student then to see the patient and start formulating in their head what's going to be some good nursing diagnosis that I can write for my patient and my care plan this week. Our nursing process then, these are all the things that we can assess that are listed here. Again, we interview the client, we look in the medical record, we do our physical exam, we talk to the family. The primary source is always the client. All the other sources then are called secondary sources, but we always want to try to get as much information as we can from that primary source or that patient. We interview the patient. Again, we have our 5 ways of completing a physical exam. When you inspect, you look. When you auscultate, you listen. When you palpate, you touch. And when you percuss, you tap or touch the patient, kind of like when you percuss a drum. And then we look at our x-rays and other laboratory results that have been obtained on that patient to help us collect data. Maybe their white count is elevated and they have a bad cough and the chest x-ray shows infiltrates. I'm not going to say they have pneumonia, but I'm definitely going to be looking at some of the nursing diagnoses that have to do with airway. As we look, the nursing process organizes your approach to delivering nursing care. In order to provide care to your clients, you will need to incorporate the nursing process and our interview process. C is the correct answer for that one. As we look at validation of assessment data, then we compare it with other sources. Any additions or corrections should be noted and added to that database. And through that validation process, then we have that opportunity to review and to reassess what we find. Our next step is to put things together, and I like to play a little game that goes back to the days of watching Sesame Street with my kids. We call it clustering data. And we only want to cluster things that belong together, and we want to make sure that the information is accurate. So we want all of the information that goes together in a logical order to help us paint a picture of what's going on. So we fit together, we try to find the gaps and fill in the gaps with our assessment. When we cluster things, we have to say, do these things usually go together? And then we sort out or cluster the data, and then we try to fit the data that goes together. So here's my friend Big Bird, and on Sesame Street he would say, you have a bus, you have beans, airplane, and car. Which of those 3 things go together and which one doesn't? And hopefully you've said the beans because it's a food and the others are forms of transportation. Our patient that has a temp of 102 has chills, a white blood cell count of 17,000, and bowel sounds present. The one that doesn't fit there is the bowel sounds being present. The temperature, chills, and white blood cell all relate to the patient having an infectious process. The pitfall to doing the clustering is that sometimes we come to early conclusions where we think we know what's going on without really looking at that relationship going together. So as we practice clustering, we'll do more of that in class. We look at this patient and we say there's a lot of data that needs to go together, and our data then needs to fit in order to cluster it. We will be practicing this more in class, but think about how it should go. That's the end of this PowerPoint.